Welcome back. We're going to continue our discussion in advanced pharmacology with cardiac medications. As a precursor to this lecture, you're probably seeing it in a series included with pharmacology. I would encourage you to come back and review the cardiac medications once you've completed or at least have started in the cardiology chapters of the program, so some of these terms will make a little more sense to you as we go through. As a reminder, medications discussed in this lecture are intended for a brief overview of common medications in the noted area and are for education purposes only. Please remember that the allowed medications, their specific doses, indications, and uses will be subject to individual states, EMS services, and medical control physicians. Always follow your local and state policies, regulations, guidelines, and protocols for specific medications in your service area. When we start talking about cardiovascular medications, it's important to understand their classification and how and where these medications work. For our antidysrhythmic medications, these target cells within the heart to resolve dysrhythmias or suppress ectopic foci. And that term ectopic foci means electrical activity that's originating anywhere other than the SA node. The Vaughan Williams classification system groups medications into four classes, class 1 through 4. Class 1 is your sodium channel blockers. Class 1A are moderate, Class 1B are weak, and Class 1C are strong. Class 2 are your beta blockers from the beta blockade. Class 3 medications are potassium channel blockers, and Class 4 are calcium channel blockers. And we'll evaluate the cardiac medications in this order to see which of these medications you're going to be dealing with. It's of important note, and I'm sure that you've heard this before in anatomy and physiology, and if you've started your cardiology studies within the cardiology chapter, that electrolytes play an important role in muscular contraction. And where these medications work and how they affect individual electrolytes will have a determination of their impact in the cardiac phase. You'll subsequently learn in cardiology chapters about interpreting ECG rhythms and how ECG tracks electrical charges and impulses as they move through the heart. But we can also visualize this in a different way based on the influx and efflux of various different electrolytes that allow for muscular contraction. We start at phase 4, and if you see phase 4 at the bottom of the graph there, that's the resting state. The cardiac cells are at rest, and they have a potential charge of negative 70 to negative 90 millivolts. This is the resting phase for the heart, and there's no real transference of electrolytes that are occurring at this point. At phase 0, when contraction starts, or when depolarization of those cells start, there's a rapid influx of sodium ions into the cardiac cells, changing the millivolts from the resting of negative 70 to negative 90, all the way up into the positive vector. Phase 1, sodium begins to decrease and potassium exits the cell. In phase 2, you can see at the top of the chart there, calcium moves in and potassium begins to exit. During phase 3, calcium movement ceases and potassium outflows continue until we reach phase 4, where we're back in that resting state. You can see now where we can modify the movement of electrolytes into and out of the cell. We can impact various portions of the contractility cycle and thus help control ectopic or dysrhythmic rhythms within the cardiac cycle. So let's look at some of the class 1 antidysrhythmics. Your class 1 antidysrhythmic medications slow the movement of sodium in the cardiac cells. Your two predominant medications that you're going to see here are procainamide and lidocaine. Procainamide is used to suppress activity of that ectopic foci and slow the conduction velocity, while lidocaine blocks the sodium channels directly and helps resolve ventricular dysrhythmia while suppressing the ectopic foci. Your class 2 antidysrhythmic medications are your beta-adrenergic blocking agents. These inhibit the catecholamine activation of the beta receptor sites, and they can both block beta 1 and beta 2 depending on the type of medication given and the dose range that you're giving it in. A note that's important to mention is they may cause massive conduction abnormalities when given with calcium channel blockers. So make sure if you're given calcium channel blockers, you're not also giving beta blockers unless it's a very specific circumstance. Some of the common beta blocker agents that you're going to see are going to be medications that end in OLOL, and that's generally the consensus with beta blockers. So metoprolol, or the brand name Lopressor, is one of those medications. It reduces heart rate during myocardial ischemia and atrial tachycardias, and is often used as an adjunctive treatment with patients having an MI and a rapid heart rate to help reduce the myocardial oxygen demand. Your class 3 antidysrhythmics medications, they prolong the absolute refractory period, and they're used to both treating atrial and ventricular tachycardias. The most common medication that you'll have for the class 3 space is amiodarone or cortisone. There's some controversy in whether or not this should be used in Wolff-Parkinson's-White syndrome, and it may cause adverse cardiovascular threats and life-threatening pulmonary conditions, particularly if it's given in the conscious patient or the patient with a pulse in a rapid bolus. These should be given over a period of time to allow that adjustment period to occur unless the patient's in cardiac arrest. Another medication you may see in the class 3 space is sotalol or betaspace. Class 4 antidysrhythmic medications are your calcium channel blockers. They have a variety of uses, including controlling heart rate and blood pressure and controlling cardiomyopathy. They displace calcium at the receptor sites or enter smooth muscle cells in place of calcium. They decrease the automaticity of the cardiac muscle and the ectopic foci, as well as the velocity or the force and speed of cardiac contraction. Some of the common medications that you'll see in this space are either verapamil or diltiazem, with diltiazem or cardizem being the most common. They help control heart rate in patients with atrial fibrillation and atrial flutter. It can be given pre-hospital and is common in several services. It's administered intravenously over a period of 2 minutes, and it does require continuous electrocardiograph monitoring and frequent blood pressure monitoring. As the case with any of the cardiac medications, if you're administering a medication at the paramedic level, regardless of its class or type, you really should have the patient on a cardiac monitor. Some other medications that are in unnamed class, adenosine is one that's common. Adenosine decreases cardiac conduction velocity and prolongs the effective refractory period, producing a pause in cardiac activity. It will produce a period of electrical silence or asystole for a period of time, generally only a couple of seconds. And it's used to evaluate ECG tracings as a cardiac electrical activity terminates and resumes. It has a very rapid onset and a very brief duration, and it's administered with a very proximal IV, preferably through a large bore, followed by a saline flush. It's also used in the treatment for atrial tachydysrhythmias. You also have alpha-adrenergic receptor agonist, and we talked about some of these medications when we talked about drugs of the sympathetic nervous system. The alpha-adrenergic receptor antagonists prevent endogenous catecholamines from reaching the alpha receptors. They can help lower blood pressure, decrease systemic vascular resistance, and oftentimes are prescribed with patients with hypertension, enlarged prostate, or glaucoma. Looking at some of the alpha-adrenergic receptor antagonists that you may see, clonidine, phentolamine, and probably more commonly labetalol, which is an alpha-1, beta-1, and beta-2 antagonist, and is given frequently in pre-hospital settings. Other medications that may affect the cardiovascular system, angiotensin-converting enzyme inhibitors, or ACE inhibitors. They alter the function of the renin-angiotensin system and cause blood pressure and cardiac afterload to decrease. Used frequently to treat hypertension, cardiomyopathy, and congestive heart failure, these patients can present with some what we would call classic symptoms. They may have a chronic dry cough, but they also, and this is a condition you need to be aware of as a paramedic for patients who are new to taking ACE inhibitors, can experience sudden life-threatening angioedema or swelling of the face and tongue. This can be life-threatening at times and may need emergent airway management. So it's important as part of your history when you're assessing these patients to evaluate for these potential causes if you have a patient who's presenting with that presentation. One of the easy ways to identify ACE inhibitors is they tend to have the suffix pril, P-R-I-L. So quinapril, captopril, benazepril, and most commonly lisinopril. Another medication that we discussed in the sympathetic medications lecture, Anticholinergic medications. These are medications that are antagonizing the cholinergic system or the parasympathetic system. Atropine is a muscarinic receptor antagonist. Its effectiveness is related to the concentration at the receptor sites as compared with acetylcholine, or ACH. We use it in treatment of bradycardia when vagal stimulation is suspected, particularly of the muscarinic 2 receptors, as this helps reverse those effects of that vagal stimulation. It's also used before airway manipulation in certain patients and in certain populations to prevent stimulation of the vagus nerve. And it can be a life-saving antidote for acetylcholinesterase inhibitor toxicity. You'll see atropine again when we talk about toxicology and fertilizers or other organophosphate toxicity. Atropine is a life-saving intervention, but you need it in significant doses, much more than we would see with the typical cardiac dose. Catecholamines and sympathomimetics. Again, this should be a review for you from our previous lecture. Catecholamines stimulate the receptor sites of the sympathetic nervous system. When we're referring to an endogenous chemical or chemical that's naturally recurring within the body, we call them catecholamines. When they mimic the impact of a catecholamine, we call them sympathomimetics, or they're mimicking the sympathetic nervous system. They all contain a catechol group and a monoamine oxidase group. They're rapidly metabolized and have a brief duration of action. Sympathomimetics are synthetic chemicals, again, that mimic those catecholamines. They include things like amphetamines, albuterol, phenylephrine, cocaine. And they have a much longer duration than the endogenous catecholamines themselves. A common catecholamine that you're going to deal with is epinephrine, also known as adrenaline. It stimulates alpha, beta 1, and beta 2 receptor sites. It can be administered intravenously, intraosseously. It can be administered intramuscularly and commonly is administered intramuscularly for things like anaphylactic reaction and higher concentrations, the 1 to 1,000 epinephrine. It can be administered subcutaneously and endotracheally and via nebulizer for certain respiratory conditions, specifically when it is the racemic preparation of epinephrine there. It can dramatically increase cardiac workload and myocardial oxygen demand, and really should be used with caution in patient that you suspect having a myocardial insult or an event. Norepinephrine or Levophed is a catecholamine that stimulates beta 1 and alpha receptor sites. It can be delivered through continuous IV infusion and titrated to the patient's response that you're intending. It can cause tissue necrosis if extravasation occurs, so be sure to check the IV site while you're administering. Dopamine is a primary medication for hypotension refractory to volume resuscitation. When we get into shock and managing hypoperfusion states, we'll note that the primary treatment in most cases is administering a fluid bolus first, and then we'll look to medications to shrink the tank or increase cardiac contractility to address the state of hypoperfusion. Dopamine and dobutamine are commonly used, and the dobutamine more so than dopamine in recent years, to help those patients who may be experiencing significant perfusion reduction due to hypoperfusion states. Milrinone or Primacor is functionally similar to dobutamine. It can be given orally or intravenously. It increases cardiac contractility while causing dilation of systemic arteries and veins. It improves cardiac output, but does increase mortality if it's used long-term. Some of the pure alpha agonists that you may see, phenylephrine or neosynephrine is a synthetic medication that is almost completely pure alpha agonist. It is a potent vasoconstrictor, has a much longer duration than catecholamines, and can cause reflex tachycardia and tachyphylaxis. Extravasation is a major concern with this medication when given IV. You can see that it's also used in over-the-counter preparations for nasal congestion relief and occasionally for nasal hemorrhage. An older medication that is less commonly found in today's medicine, but is still worth noting. And we'll talk about digitalis again when we talk about toxicology, because there is an entire toxidrome dedicated to digitalis. It increases the strength of cardiac contractions. You're not likely going to be giving digitalis anywhere in the pre-hospital setting for sure, but you may still experience some patients who take digitalis as a prescription. So it's worth noting its impact to EMS. It slows conduction through the AV node and slows the heart rate, and it can produce a wide variety of adverse reactions. Like I mentioned previously, there's an entire toxidrome dedicated to digitalis. Direct vasodilator medications, these are often used in the management of uncontrolled hypertension, congestive heart failure, for myocardial infarction patients, patients who are experiencing cardiac ischemia or cardiogenic shock. One of the more common medications, and you've seen this medication, maybe not in this preparation, but you've seen this medication since you were an EMT basic, nitroglycerin, nitrobid, or nitrostat, dilates the veins and coronary arteries. There's a physiologic response that typically relieves chest pain and decreases blood pressure, and adult doses, if we're giving it intravenously, begin at 5 micrograms a minute, but can be increased up to 200 micrograms per minute IV. Long-term use of nitroglycerin is prone to causing tolerance, so lower doses may not be effective if the patient has been on nitroglycerin for an extended period of time. Tablets are also prone to degradation, especially if they're exposed to the elements, extreme heat, or sunlight. And they should never be taken by patients taking phosphodiesterase 5 inhibitors for erectile dysfunction. Phosphodiesterase 5 inhibitors are a class of erectile dysfunction medications, and it's important that you ask those questions prior to administering nitroglycerin from a reliable historian, either the patient or a family member if the patient is unable to respond, because there's a concomitant effect of blood pressure reduction on patients taking those medications along with nitroglycerin. Sodium nitroprusside, or nipride, is also a potent IV vasodilator. It affects the smooth muscles of the arteries and veins. There is an adjustable IV fusion rate to maintain optimal blood pressure, and it has rapidly decreasing effects once infusion stops, meaning it's metabolized quickly, so it's easier to control. Hydralazine is used for hypertensive emergencies, pulmonary hypertension, and can be used in pregnant patients with eclampsia and preeclampsia. It dilates the arterioles and lowers pulmonary vascular resistance. In the emergency situation, or if we're administering it pre-hospital, it should be administered over a period of at least 1 minute, but then repeated in 20 or 30 minutes if the patient presentation dictates. Another class of medications that will impact your cardiac patients are your diuretic medications. These are generally designed to correct volume overload, manage congestive heart failure, and improve respiration in your pulmonary edema patients. They can potentially preserve kidney function, but use of diuretics in patients who have underlying kidney insult is generally contraindicated and should be used in caution. Furosemide is used as a diuretic medication management for hypertension, congestive heart failure, kidney dysfunction, and liver disease. Again, use of diuretics in the pre-hospital setting, you really should be careful with. There's a tool that we don't have access to that they do have access to in the facility, and that's the ability to draw labs and understand the electrolyte values for patients prior to giving these medications. Keep in mind, and we discussed this a little bit with our fluid lectures and some of our anatomy and physiology and homeostasis lectures, that just because a patient has an excessive amount of fluid in their third spaces, so if we're talking pitting edema or pulmonary edema, doesn't mean that the patient has adequate intravascular fluid or adequate intracellular fluid. And taking a patient who has a reduction in intravascular fluid or is intravascularly and intracellularly dehydrated and giving them Lasix could cause a toxic shift in the concentration of electrolytes. So these medications should be given with care, and you should consult your medical control physician and your protocols and guidelines for administering these medications. They're not as safe as we once thought they were. Another medication that you may see that's a common diuretic is the mannitol. It's an osmotic diuretic, and this is used to decrease intracranial pressure, specifically when it's associated with cerebral edema. There's a table found here on the screen that you can see that breaks down some of the diuretics based on where they work or their specific classification type. You can see that furosemide, Bumex, and Demodex are all part of the loop diuretic category, and they disrupt sodium reabsorption in the thick ascending limb, the loop of Henle within the kidneys. Your potassium-sparing diuretics are things like aldactone. Then you have thiazide diuretics, which are things like diuryl. You also have vasodilator nitrites like hydralazine and combination drugs that may be used to produce the same effect, like hydrochlorothiazide and spironolactone. Antihypertensive agents are used to treat hypertension. It can be used with diuretics or beta blockers or a combination of the two. Patients taking antihypertensive may have symptoms of hypotension, specifically orthostatic hypotension, so make sure you monitor that carefully. And here's another list of some common medications taken by patients that you may see in the pre-hospital setting that are cardiac related. Specifically, pay attention to your beta blockers ending in OLOL, your angiotensin converting enzymes ending in PRIL, your alpha agonist, your vasodilators, and then your cholesterol lowering drugs such as statins and niacins.